Commissioner Malatji. When you're ready, you could start with
Thank you very much, Shirin. And I think some of you attended the actual hearing in the Eastern Cape. I see one or two familiar faces from that meeting. So just to quickly go through the initial investigation came from Koramouth and in the Eastern Cape. The Commission expanded it to include communities from Isilatsha, Neer, Lusikisiki, and Zitulele. And the issue was really on the lack of access to emergency healthcare services. The Commission had convened the hearing. We invited, obviously, apart from the communities themselves, organizations who work in the Eastern Cape, like the Eastern Cape Health Coalition, which comprises a number of different organizations. We also invited expert witnesses to come or to present submissions to the Commission, specifically in relation to emergency healthcare services. This is a problem that doesn't exist just in the Eastern Cape. It's a problem that exists across the country, as the Commission's healthcare report, which was launched in 2010, clearly illustrated. We obviously held the hearing in the Eastern Cape because one of the realities is that the lack of rights across the board impacts and is felt worst by people who are poor, and the apartheid spatial geography also determines the entrenchment of that poverty and inequality. So the fragmented healthcare system in the Eastern Cape is particularly pronounced in areas in the former Transkei, Ciskei position. So the Commission, in addition to wanting the communities to come and present, we wanted government departments, Department of Health, trying to make sure I have the exact, the Eastern Cape Department of Health, the Eastern Cape Provincial Planning and Treasury, and the Eastern Cape Department of Roads and Public Works, as well as the Provincial Government Fleet Management Services Trading Entity, were all invited. And we had representatives from those departments. Some of them didn't arrive on the day that they were supposed to. The Commission, in terms of its power, also one of the key things I think that the Commission is able to do that civil society organizations have much greater difficulty in doing is to ensure that those with power are actually able to be brought to different meetings to address human rights. And in this instance, to listen very closely to what communities were saying were the devastating impacts of the lack of emergency healthcare services on their lives. We heard, for example, the fact that there were people, elderly people who had never seen an ambulance in their entire lives, despite having experienced great emergency situations. We heard also about the disrespect that people received when they called the call centers. Some of them spoke about being told disparagingly to go and use their childcare grants or old age grants, and you know that the childcare grant is about 330 Rand, the old age grant is about 1,410 Rand, and in the context of huge unemployment, those grants are used to support not just one individual, two individuals, it's used to support often entire extended families. So the actual disrespect implied in telling people who are poor that you must use your grants to get your transport. People spoke of the indignity and pain of being transported in wheelbarrows, for example. Those who managed to call an ambulance and actually get a commitment that an ambulance was coming often found that the ambulance arrived too late or not at all. Community health workers who are operating in the communities spoke in anguish of actually experiencing the death of women in childbirth because there were complications and the community healthcare workers were not trained to be able to treat them. People living with disabilities shared humiliation when, for example, people on wheelchairs, using wheelchairs, were not allowed to take the wheelchairs into the ambulances if the ambulances came. And the terrible state of rural roads made it impossible for ordinary ambulances to get through to many villages. We also saw the generosity and solidarity that enabled many people to survive in such circumstances. There were stories from many villages of people who said that the nurses, the local nurse, would facilitate, through her own salary, facilitate the transport to the hospital. A young man stood up and said that from the hall, he was actually in contact with his mother, getting somebody to take his mother, who was very ill, to a hospital. He was organizing private transport, but he had left his mother knowing that she was ill because he had felt that it was really important to come to the hearing so that in the future his mother and other people like her facing emergency healthcare situations would actually, their situation would change. And so what we saw was that people were speaking not just for themselves as individuals, and not even for their families, and not even for their communities. They were actually speaking for larger numbers of people across 4 parts of our country, and which are predominantly, and which reinforce the apartheid era patterns of inequality and discrimination. And I think through the hearing, the Commission's role was to try to ensure that the departments present actually gave commitments at the meeting and then subsequent to the meeting. So that we obviously have the report which we are launching tomorrow in Koromat, where the initial complaint came from, and we've invited communities from the other villages which presented and the other areas which presented to come to Koromat. But the issue of getting, so the report outlines a whole list of recommendations, and we're happy to share those recommendations with you. There's a need for, and I'll just give a few of them. There's a need to increase the number of ambulances, especially the number of ambulances that are specially designed to navigate the rough terrain. So, for example, that are adapted in terms of 4x4 capacity. That all ambulances should have proper equipment. There's a need to train and recruit more staff, particularly in rural areas. The action needs to be taken to address the poor attitudes and service delivery of staff. What we also saw in terms of budgets was, for example, there was no line item for call center operators. And so other people were filling that role. So there's a need for budgetary matters to be addressed. The issue of the roads, for example, what was very clear from the submission by the department was that it'll take, I can't remember how many years they talked about, but it would take decades before the roads were able to be addressed, because even though there's a huge budget for infrastructure that has been announced, that infrastructure budget is primarily going to be used to address the interests and the needs of business, not the needs of people who are poor. And so the medieval conditions that we heard about are going to persist unless those roads are changed. And that's not the Department of Health. That's about the entire budgeting process. So there's a very real challenges about the country's priorities in terms of people who are poor. But in terms of the Department of Health and the specific things that we heard about is that they would ensure, that we've recommended the way in which the transport services operate, particularly for people with mental and physical disabilities. there needs to be clear for women who are pregnant and who might face complications, etc. There should also, patient transport must be available, to transport patients back to communities after receiving treatment, especially in the evenings when there's much more exposure to crime. The department should develop a formal policy to address the difficulties in locating communities. So they need to be able to use modern technology to find where the community is that they've got to travel to. There are parts of the country that are difficult to find, but with modern technology we can do that. The department should also be able to ensure that persons with disabilities who are using wheelchairs should be able to travel with their wheelchairs, and must ensure that a friend or family member should be allowed to travel with people who are elderly, with people who are with disabilities, with a pregnant mother, etc., to the hospital. The transfer and delivery of patients to hospitals must respect the dignity and human rights of people. The emergency medical services should be available to all persons requiring immediate or timely care, including terminally ill patients. All of us sitting in this room would expect that if ourselves or our family members faced an emergency healthcare situation, we would be able to get access to that. There should be no double standards in our country. The department with local districts and municipalities should consult communities in developing health-related policies, plans and programs. And there should be access to information. And there should be clear policy and procedure to be followed in the event that an ambulance doesn't arrive. After 6 months, the department has been requested by the Commission to provide the Commission with a detailed plan on how it will improve the delivery of emergency medical services and to report on what steps have already been taken. What I'd like to share before handing over to my fellow panelists is the commitments that have already been given at the meeting and subsequent to the meeting. The commitment that was given in the meeting itself was that the budget for emergency medical services to communities has been increased to allow the department to improve the delivery of services by purchasing more ambulances. There was a clear commitment that they will purchase more ambulances. They will ensure that all ambulances have proper equipment, and that more 4x4 ambulances will be purchased. They committed to training and employing more staff with the additional budget that they have. They committed that ambulances have been fitted with tracking devices so call centers can see where ambulances are and can speed up delivery. The number of vehicles to transport people between health facilities and to appointments will be increased, so the service will be more reliable. The Department of Health and Department of Roads and Public Works committed to improving the condition of the roads to certain hospitals. Although this will take a long time, this will certainly improve healthcare facilities if this commitment is given effect to. New policies have been put in place in terms of response times. There was a clear commitment at the meeting by the Dr. Tobile Mengashi, who's the Superintendent General of Health in the Eastern Cape, who said that no person will have to wait for an ambulance for longer than 4 hours at the most. He spoke about trying to get there by within an hour, 2 hours, but no longer than 4 hours. And if an ambulance is slow or does not arrive, he provided the names and numbers, the cell numbers of the district managers to contact to make sure the ambulances respond. So those were significant commitments that were secured in the meeting itself and subsequent to the hearing. I think I'm going to stop there in terms of recommendations and commitments secured, and I'm going